us here? Okay. Okay, now Cushing's disease. It is an interesting disease. I remember my first case of Cushing's disease when I came to Minnesota in 1993. So I diagnosed it based on the clinical science because it's truly a clinical disease. And then I went to the endocrinologist, so now you're going to treat. And he said, no, you are treating it. I said, no, I don't want to treat Cushing's disease. I have no experience with Cushing's disease. You are treating it. And I'm so grateful to him because I treat one case and then I treat all the other cases that came to me. It's not that we see that many, but we do see Cushing's cases in derm because, again, of the hair loss. So, and they don't come to us if they're not having complications. If they do, they come more to medicine. Okay, so it's like in the belly of this dog, it's saying, I have Cushing's disease. Okay, it's really clinical, more than hypothyroidism. So we'll talk about the causes briefly, then the diagnosis. I'm including here history and clinical science because, again, this is extremely important in the diagnosis of Cushing, as in hypothyroidism, as in any other skin disease. The clinical pathological findings that can support a presumptive clinical diagnosis. Screening tests, meaning the test that you use to diagnose the disease and then to localize it. And in treatments. So there are 4 different types of Cushing's disease. So pituitary-dependent and adrenal-dependent Cushing's or hyperadrenocorticism, ectopic ACTH syndrome, ACTH-independent and food-dependent hyperadrenocorticism, and the iatrogenic form. So the 3 first are spontaneous forms of Cushing's disease. The ectopic ACTH syndrome and the ACTH-independent, food-dependent syndrome, extremely rare. So we'll be focused today on the pituitary-dependent and adrenal-dependent Cushing's. Okay, so again, in this category, most cases you'll be seeing are pituitary-dependent cases. They account for 80 to 85% of the cases. Much fewer cases will be adrenal-dependent Cushing's disease. So just review again the hypothalamic pituitary, now adrenal axis. This is what's normal, just to refresh your memory. So hypothalamus secretes CRH, which is a corticotropin-releasing hormone. That hormone reaches the anterior pituitary and tells the corticotropes to synthesize and secrete ACTH, so adrenocorticotropic hormone, and ACTH reaches the circulation, goes to the adrenal glands, the cortex of the adrenal glands, and stimulate the zona fasciculata and reticularis primarily to synthesize and secrete cortisol. So cortisol reaches the circulation. When it gets to a concentration that homeostatic, it feedbacks to the anterior pituitary and tell the corticotropes stop producing ACTH, and it also feeds back in the hypothalamus, saying, CRH, no. What happens with Cushing's disease? So pituitary-dependent, again, the most common form of spontaneous Cushing's disease you'll be seeing. These dogs, most of them, have a very small functional tumor in the pituitary gland. And that tumor produces constantly ACTH, okay? The tumors do what they want, and it's constantly producing ACTH. These tumors are typically small. They are microadenomas. They can become larger, and in which case these dogs with Cushing's can have neurologic signs because of this larger tumor. But this is rare. Most of the time they are small, functional tumors that secretes constantly ACTH, okay? So what happens then? They are secreting ACTH, in stimulating the adrenal cortex, again, zona fasciculata and reticularis, to produce cortisol. Eventually, bilaterally, they become hyperplastic. So they become thick in the cortex of these adrenal glands. Lots of cortisol constantly reaches the circulation, but because it's a tumor, that negative feedback doesn't work. So the tumor doesn't mind. The cortisol is there. They said, go away. I will keep producing ACTH. That's what happened. Now, with the adrenal tumor, which occurs, again, 15-20% of the cases you've seen, so much less, usually they are unilateral. They can be bilateral. It can be an adenoma or an adenocarcinoma. And they are producing cortisol completely independent of the pituitary gland, okay? So then all that cortisol reaches the circulation, and because the feedback mechanism is working here, so pituitary gland is fine, there's no tumor there, and then it stops secreting ACTH. So level of ACTH goes down, and then what happens is the parenchyma of the adrenal cortices that are not affected by the tumor atrophy. And so then you have the tumor here, so producing the hormone. This portion here that's not affected will be atrophy. You can see the comparison of this hyperplastic, but normal is in between that, and this is completely atrophy. So that's the difference here between these two forms of this Cushing's, cause of Cushing's, okay? And again, I mentioned it's a clinical disease. The changes on the skin and also the clinical signs, more than hypothyroidism, it tells us, the dog tells us, I have Cushing's disease. It's written on their forehead. And obviously, I'm talking more about the advanced, more chronic disease that's typically we see, because those changes are clear there. So you may be seeing a case that's more at the beginning of the disease, but you still be able to see some changes that will make you clinically, initially, think of the disease. They do, again, before you took the history, that suggested you see these changes on the skin. Initially, you may not see the muscle atrophy much at all in these dogs, but you'll be able to see thin skin. You may be able to see some comedones there. And so, and maybe hypotrichosis at that point. So the hair is shedding, new hair, it's coming back, okay? Or you may see a case already very advanced that's very easy to diagnose clinically. But we don't just stop there, right? You have to do some testing to not only confirm your presumptive diagnosis, but also in this disease to localize where the problem is. So we'll be talking about that. So history, and not all these clients will tell you all of this we'll discuss here. So polyuria, polydipsia, and polyphagia occur, I would say, in more than 80% of the cases. Not to say 100%, but if you read the literature, it's more than 80 cases that I've seen 100%. So those are very common signs. And so it's interesting, nobody knows the pathomechanism of polyuria, but it's believed that cortisol inhibits ADH, the antidiuretic hormone, in the hypothalamus. And so it's causing a central diabetes insipidus, or at the level of the kidneys, the collecting distal tubes or collecting tubes. So inhibiting the action of ADH at the tubes, and then they don't concentrate urine, release a lot of water in the urine, osmolarity increase, then activate the osmoreceptors in the hypothalamus, and usually when it happens when you are dehydrated, again, it stimulates ADH, but ADH is not working here. And then these dogs drink more, and they drink a lot more to compensate for all that water loss in the urine. And so that's, again, the polydipsia, right? So polyphagia, it's an effect of glucocorticoid directly in the brain of these dogs. And we have to tell them that they are not hungry. They don't need more food. It's just, well, they are hungry, right? They are polyphagic, but they don't need more food, okay? It's just the effect of the hormone in their brain. So painting, so as you know, they paint a lot. Even when you give glucocorticoid to a patient, they will paint a lot. In the case of Cushing's, it's easy to understand. It's atrophy of the muscles, respiratory muscles, say the intercostal muscles, compression of the diaphragm because of fat deposition in the abdomen, enlarged liver, okay, compressed to some extent. Fat is also deposited in the mediastinal. And there is some mineralization of the lung parameter, parenchyma, okay? So all that contribute to some extent to the painting. And exercise intolerance due to catabolic effect of cortisol and glucocorticoid in the muscles, okay? It has a catabolic effect in muscles, in lipids, and carbohydrates, but glucocorticoid is gluconeogenic. So it wants to produce glucose that's stored in the liver as glycogen for energy. We all do that. We all have that glycogen in our liver, that steroids, the glucocortisol does for us, okay? But again, in cases of Cushing's disease, they do that in expense of protein and fat, okay? Believe it or not, they convert amino acids into sugar and fat also, and that goes to the liver and it's storage as glycogen. Okay, so that's that muscle atrophy that we see with the disease. And that leads again to this exercise intolerance that they have. Okay, now it doesn't go. Go, help me. Whoosh. Okay, whoosh. Did I miss one? Let me just go back here. Okay, no. Okay, then we, clinicians, we see these dogs. Then we see the skin changes, which we'll talk a little bit more about in a minute here. So muscle atrophy, you may see it in various degrees in these dogs, very advanced degrees. It will be quite visible to you. Distended abdomen, which we call the pot belly appearance, and that happens because the muscle atrophy, the fat accumulation in the abdomen, as I mentioned to you, also the enlarged liver, and also distended bladder. And these muscles are weak, and so that weight makes that belly kind of saggy and pot in appearance, okay? And again, you see more in advanced disease. And you may be able to palpate or not that enlarged liver. And here's why. Okay, we'll look at skin here a little bit. Okay, hair loss. Glucocorticoids inhibit anagen. Okay, anagen is that growing phase of the hair follicle. So a lot of hairs will go to the resting stage, telogen, and they don't hold inside the follicle very strongly. So they fall off more easily. Then you see the hair loss in this case. Again, tends to be symmetrical. Distribution is similar to hypothyroidism. It's non-inflammatory. It's non-pruritic, okay? Thin skin, which we don't see with hypothyroidism. Actually, hypothyroidism, very chronic cases, you have thick skin because of accumulation of mucopolysaccharides in the skin. But I saw one case of we call mixed edema, which again occur in very chronic cases. People tend to more supplement, as we discussed before, with thyroid hormone than miss a diagnosis, because they give so much that it would be rare to miss a diagnosis and you see a very advanced case. So, but thin skin here is that catabolic effect of glucocorticoid on protein, fat, and also carbohydrates, okay? Now, calcinosis cutis, I'm sure you've seen that skin calcification. That's a nice marker for either iatrogenic. I actually see calcinosis cutis more in iatrogenic Cushing's than spontaneous Cushing's, but either one, that's a marker. So, but with everything else. We don't understand much how this developed, but one hypothesis that there is that increased protein catabolism leads to the formation of an organic matrix that attracts calcium and phosphorus in forming then that calcinosis cutis, or skin calcification. And these animals are prone to develop secondary infection. You can imagine these changes of skin, you change the barrier, okay, in various ways. Just an example here, the hair loss is non-inflammatory, lots of comedones. It's hard for you to see, that's why I put this picture here. It's just to show the comedones. Comedones, tons. Very non-specific, and this dog happens to have a scar here. Come on. Oy, oy, oy. I don't want to get late, because then I want here. And look at this calcinosis cutis, okay? So these plaques, okay, coalescing are skin calcification. Sometimes you see very thick, dark crusts covering these areas, so it can present in different ways. And look at this belly. How distended. Look at the thin skin. Look at the vessels that typically you don't see so easily, those vessels. Look at the beautiful comedones, all of that. And loss of elasticity in the skin of this dog also. It's written there, right, to you. I hope it is. I have Cushing's disease, okay? And this is actually a case of iatrogenic Cushing that medicine had. They were treating autoimmune disease, chronic. And so, actually I should say immune-mediated disease. So, immune-mediated thrombocytopenia. And this dog was lost to follow-up, and he was on high dosage of glucocorticoid for a long time. And he had calcification in multiple, all signs of Cushing's, but calcification in multiple areas of the body. So you can see here, it's hard to see, the plex was firm there, was ulcerated in this case. So and look at this, it's another medicine dog. It was a large dog being treated for one of these immune-mediated diseases, also high dosages of glucocorticoids for a long time. And he started to begin with a cubital ulcer. Imagine the skin very thin. That heavy dog started with the ulcer, and the ulcer expanded. And you know, glucocorticoids delayed healing. And so it was there for a long, slowly resolved when they, again, changed the treatment eventually of this dog. But I lost him to follow-up. But it was improving, it was going the right direction. But look at this. So medical complications with Cushing's. So pyelonephritis, these dogs are prone to develop UTI. Not always it will be symptomatic, okay, because of the diluted urine. So they have polyuria, but don't have polakiuria. You don't see that in these dogs. So in that medicine now, it's even say dogs that you isolate the bacteria in the urine, but are known clinical for a UTI, you should not even treat. But that happens with dogs with Cushing's, or dogs that you're treating with glucocorticoid for a long time, more inappropriated in the cases, and they can develop UTIs. And then that ascends to the kidney. And some of dogs may have pyelonephritis, okay? Hypertension, glucocorticoids are important in controlling the blood pressure. If you have a population of dogs with Cushing's disease and you take the blood pressure, about at least 50% is reported to have high blood pressure, okay? It increases the sensitivity to alpha-adrenergic receptors in the blood vessels, induce the secretion of endothelin that's produced by endothelial cells and have a very good vasoconstriction effect. Okay, it decreases the synthesis or vasodilators like prostaglandins. So it has a significant effect in controlling blood pressure. Diabetes mellitus with Cushing's disease. If it was cats, I would say 70–80% of cats with Cushing's disease develop diabetes at one point of their disease. But dogs, 5–10%. You can have hyperglycemia, but not diabetes mellitus in large percentage of dogs with Cushing's. Urinary calculi, so they are at higher risk to develop calcium oxalate or calcium phosphate calculi, okay? Urolith, okay? Pulmonary thromboembolism. These dogs with Cushing's are in a hypercoagulable state, so they release through the urine also the anticoagulants, antithrombin 3, for example, it's one that's in smaller concentration in dogs with Cushing's disease. So they can develop this thromboembolism, usually pulmonary thromboembolism. So that's why you see the medical complications of Cushing's. You see the importance of treating the disease. Because some people say, should I treat? Yes, you should treat dogs with Cushing's. Did I pass a slide here? No, okay. So then diagnosis. Clinical pathologic changes again that can help with the diagnosis. The tests that we use to diagnose the disease answer the question, does my patient have Cushing's disease? And the test to localize it, pituitary or adrenal. Only test the patient when clinical signs in the history are supportive of the disease, okay? Because they are false positives with this test, okay? So, and you know how to treat Cushing's disease. There are severe side effects. You can make these dogs with hypoadrenocorticism with the treatment. So you really need to confirm that that's what it is to put them on the medications. Okay, CBC, stress leukogram. Okay, large percentage of dogs. And again, almost all diseases, mainly systemic illnesses, you see a stress leukogram. So it's not specific at all. Chemistry profile, that, as you know, can help us. So increase in alkaline phosphatase. So it can be glucocorticoid induced. That happens in the dogs, not in the cats. And so it also do these changes in the liver dilation of the hepatocytes because they have lots of glycogen stored there that can impinge in the bile tracts and then stimulate the activity of alkaline phosphatase there. Eventually increase in other liver enzymes because of hepatocellular damage. Low BUN, I don't mind much, but that's probably the urinary washout, and so in the kidney because of all that polyuria going on. High glucose, it doesn't mean diabetes mellitus, hyperglycemia, okay? So frank diabetes mellitus is rare, so 5–10%. Yes, if it is in the urine. Did I put that there? High glucose, I didn't put it in the, if you have the urine, yes, it's in the glucosuria there. Then diabetes, right? So you pursue that. High cholesterol, you can see that also. Again, you weigh low urine-specific gravity, not uncommon. It's isostenuric, okay? Proteinuria. In this, there is an association with dogs with Cushing's and proteinuria and high blood pressure, okay? So keep that in mind. And again, plus or minus a urinary tract infection, and in a small percentage of dogs, you're going to have the glucose in the urine. And again, most of these changes are non-pathognomonic. Screening tests. Again, you want to answer that question. Does my patient have Cushing's disease? You have a high index of suspicion based on the clinical signs and the physical examination findings, but now you want to confirm. So what are the tests here? Urinary cortisol creatinine ratio, low dose dexamethasone suppression test, and ACTH stimulation test. Let's talk a little bit about each one of them. So urine cortisol creatinine ratio. This test you're only going to do if you have a patient that it's not that classical of Cushing, but there's some signs of Cushing's. And you said again, because I asked that question to myself, would I sleep tonight if I don't do this? Because otherwise I'll be thinking about that patient all the time and I don't sleep tonight. So if you say, no, I want to see if this dog has Cushing's disease. But again, index of suspicion is not high, okay? Then you can do this test because it has a very good negative predictive value. Meaning, if it's negative, the chances that your patient has Cushing's disease is very small, okay? So, but the problem is this test to diagnose, when everything it's saying, it's written there, I have Cushing's disease, don't spend the client's money with this test, okay? Because it's not specific. A lot of other systemic illnesses will have a high cortisol creatinine ratio. Very, very sensitive. Yes, Cushing's will be positive. But if you do that, it's positive, you have to do other tests, okay? If it's negative, you said, okay, I have to think about a different disease, okay? If that makes sense. Okay, use for cases where your index is low, and it's just how the owner, if you're doing that test, ask the owner, first, the owner was in the office to bring the urine, they collect at home and bring it to you, but wait 3 days or so, just to that stress of being in the hospital to not interfere with the test results, okay? Low-dose dexamethasone suppression test. And that test, it's used quite a bit. The gods of endocrinology, the authors of the main endocrinology book, they like this test a lot. I actually use more ACTH stimulation test because it's a 1 hour test. This is an 8 hour test, okay? But again, it's actually much cheaper because the ACTH that we do the ACTH stimulation became very expensive, okay? So, but it's an 8 hour test and it's evaluating the pituitary adrenal axis. It can differentiate between pituitary and adrenal in about 60% of the time, okay? And we'll talk about that. So with one test, you can diagnose and maybe localize the disease. That's definitely an advantage of this test. And again, it's an 8 hour test. The dogs have to stay in the hospital for 8 hours, okay? So you inject 0.01 milligram per kilogram of dexamethasone sodium phosphate, IV, okay? Collect the sample before, at 4 hours, and at 8 hours. The results come to you. Look at the 8 hour. See, does my dog has Cushing's? And you're going to see it should not suppress that dexamethasone because it's a tumor there. It should not suppress. And the adrenal tumor produces cortisol independent of the pituitary. You can give 10 times more, it won't suppress ever with the adrenal tumor. But with the pituitary, it can. And so in some cases, but it's a very sensitive test. Most of the time with this test, it will not suppress. That dosage doesn't do anything with that tumor in the pituitary, okay? So, is that something wrong there? Ish. Did I step in anything? Okay. So, what no suppression means. The laboratories may have different cutoff values to determine suppressed, non-suppressed, okay? So they help you with that, which is good. For us, the cutoff is 1.4. And so below that is suppression. That or above, it's no suppression. And that's what you do first, okay? I know you have something at 4 hours, but go to the 8. No suppression, Cushing's. Now, can I localize it? Then you go to your 4 hour. Remember, the adrenal doesn't suppress, ever. Okay, the adrenal tumor, that cortisol won't do anything with it, okay? So then at 4 hours, 60% of the dogs will suppress. And so the value will be below 1.4 micrograms per deciliter. Then you can say pituitary, okay, in about 60% of the time. Very good sensitivity. And so 95% of the time. Are you still with me? Yes, for you. Okay. And again, I mentioned to you, low-dose dexamethasone suppression, ACTH stimulation test, we can have false positive results. And that's why, again, only do this test if the history and clinical signs are supportive of the disease, okay? Okay, that's why we just mentioned that. Now, ACTH stimulation test. I really like this test, but suddenly the pharmaceutical companies, they increase the cost of ACTH. Do you have ACTH here? Yes. Yes? Is it expensive? Yes, they are true, but I'll see if you are using the protocol that the clinicians, people started to do some research and see, can we use a lower dosage so we can make this test cheaper, okay? And they did. And so, but again, here you are evaluating the reserve of cortisol in the adrenal glands, okay? Like the TSH stimulation test for hypothyroidism, the reserve of thyroid hormones in the thyroid gland. Here's the reserve. I like this test for that reason. So doesn't differentiate pituitary from adrenal, but it's the only test that differentiates is spontaneous from iatrogenic Cushing's, okay? And it's a test that's often used to monitor response to therapy. So is that what you use, cosintropin? Not the gel, right? Because the gel, there's so much variation in the bioavailability of the gel, it's not recommended, okay? So previously was this 5 micrograms per kilogram, IV or IM, okay? And you collect before and 1 hour after. But now they know that this is accurate also, this dosage. So you can use this dosage to diagnose Cushing's, okay? So 1 micrograms per kilogram, but given IV, don't give that lower dosage IM, okay? Is effective and less expensive. Okay, so how do we interpret that? Remember, in the case of pituitary-dependent, 80-85% of the cases, you see that the constant ACTH stimulated the adrenal cortex to keep producing cortisol, and they become hyperplastic, hypertrophic. So they have a lot of cortisol there, okay? And the tumor too, the tumor does produce also cortisol, but the sensitivity as a diagnosis, that's why the sensitivity of ACTH and the gods of endocrinology don't like ACTH as a diagnostic test, as a test to monitor response to therapy, yes, but it's because of the adrenal tumor. But the adrenal tumor occurs much less often than the pituitary. So for pituitary, I think this test is very good, okay? So, but there is the cutoff. The laboratory will know that cutoff, it will tell you. So if it's equal to 20 micrograms per deciliter or higher, that's Cushing's disease. So a normal dog will stimulate also, will be an incremental change from baseline, but it won't be this much, okay? And again, as I mentioned before, does not discriminate between. You have to do another test. That's an advantage of the low dose because you may be able, 60% of chance, to localize with one test, okay? And again, accuracy is that. As for the low dose, false positive exists. But again, when they've done a study, and the publication tells us less often with the ACTH than the low dose. So it has less of false positive cases in this case. But again, those tests you're only doing if everything is say, I have Cushing's disease there, okay? Now, discriminating test to localize. Is this important? Some people don't localize. I argue that it is. Why? To talk to the client about the treatment options. Yes, nowadays we have medications that you can use to definitely the pituitary, but also you can use that medication to treat the adrenal tumor. It's harder to get a good outcome with that same medication. The ideal treatment for adrenal tumor, it's removing the adrenal gland. Easy saying, a lot of these dogs are not good, even conditioned for surgery. And again, it can be complicated, but at least you discuss the options with the owner and prognosis also, okay? So yes, localize. Then you have the laboratory tests. You can use the low dose, we mentioned that, 6% of the time you can localize the disease. The high dose, you're using here 10 times the low dose, and endogenous ACTH. And you have the imaging, abdominal radiograph and abdominal ultrasound. So low dose DEX, we talked about it already. I'll pass because you're tired, and so we'll go there. So 60% of the time, if there is suppression at 4 hours, then you know that it is pituitary dependent, okay? So you have that there. We have two ways of interpreting that, less than 1.4 or less than 50% of the baseline. Then high dose. So again, you're using 10 times, so you're using 0.1 milligrams per kilogram IV. Now, we don't like much because the sensitivity, so the accuracy to diagnose the disease is relatively low. You can miss 25% of the cases, so 1/4 of the cases. Not very good. You may say, well, you miss more with the low dose, but low dose is not used for that purpose. It's more to diagnose, but you measure the 4 to see if you have a chance to localize it with that test, okay? So, but that's the protocol, 10 times the low dose. And then in this case, you should, if it is Cushing's, you should see suppression. The low dose doesn't suppress, but if you increase 10 times, it will suppress the cortisol. So in about 75% of the cases. So I wish it was a better accuracy, okay? Endogenous ACTH. Remember again, if you think what happens with Cushing's, most of the cases, tumor producing ACTH. Then the ACTH level will be high, okay? Adrenal, remember? Adrenal producing, cortisol independent of the pituitary. Negative feedback is working, so ACTH will be low. So one very high, and then the other one low. So you can localize that. It's very good. I didn't put the accuracy here, but it's 80% of the time or so, okay? And there are the cases that will fall in between that you cannot localize, okay? And there is, I'm not going to go over this, otherwise we cannot get to treatment, but there is a protocol that you have to apply after you collect the samples. Put in a specific tube, it's added, how do they call that? A protein, because otherwise ACTH binds to the tube, and then you have a spuriously low ACTH, okay? Okay, abdominal radiograph, not very sensitive. So you can typically see these tumors when they are calcified, and they calcify in about half of the time, and or if they are more than 2 centimeters in diameter. And not always they will be. So sensitivity of radiograph to localize. So is there a tumor in the adrenal gland or not? Because if it's not, then it's pituitary, because you won't see in a radiograph the thickening of the adrenal cortex in case of pituitary dependent, but not very sensitive. So what people do typically if using imaging, okay, that can be more expensive than the other tests to localize, is the abdominal ultrasound. And that's pretty good, okay? In pituitary dependent, you should see an enlarged adrenal gland, and the shape, it's normal, it's not bumpy, so. And in the adrenal tumor, a regular adrenal gland, often in one side, but it could be both sides. So a good radiologists are very good at really localizing the disease with an ultrasound. And also, again, I said that ultrasound is not good to determine if it is a adenoma or adenocarcinoma. But if it is metastasis, will tell us, right? So it's an adenocarcinoma. And you're seeing there if there is any other organs affected. So treatment. Are we okay still? Are you guys exhausted? Poor you. So do you want me to talk about the treatment? Okay. So why treat, right? So improve the quality of life of the dog and the owner, okay? Avoid complications. We mentioned about the complications, and some of those, these dogs can die, okay? And increase, again, survival time. All the complications, you have that in your slide, so I won't go over them. One thing that I learned, I didn't know about this, but was a clinician talking to me, dogs with squishes that have gallbladder mucocele have a worse prognosis, okay? So you know that. I didn't know, I learned that. So all these possible treatments. I added the ones I checked with you in the garage and what you had here. So I added some that you use that I have minimal experience with, but we'll get there, okay? And the ones we use. Then ketoconazole. So as you know, inhibit steroidogenesis by inhibiting the liver, some of the liver P450 microsomal enzymes, especially that 11 beta hydroxylase, and also the cholesterol side chain cleavage. And efficacy, look at the range, 25 to 90%. I did use ketoconazole a long time ago in Brazil when we didn't have midotane or PDDD, because we didn't have all the other drugs, either trilostane or eldeperenil. So, and I didn't like it. I didn't help my patients. I didn't use a lot in a lot of the patients, but the outcome, some dogs improved to some extent. Their quality of life was better, and quite a few did not. Okay, so when they increased the dosage to 30 milligrams per day, so a lot of these dogs had side effects, so it was kind of a disappointing. Do you use ketoconazole quite a bit here? Huh? You do? No?
We don't have, we are maintained, we don't have any presence.
Oh, but do you ketoconazole you don't use? Okay, it's used. Okay, good. You tell me your success rates. It's a side effect again, GI, quite a bit. Increasing liver enzymes is expected. Hepatotoxicity, if you go at the higher dosage, okay, can occur. And it's interesting, when you use it for a while, lightening of the hair coat. I haven't seen that, but it's reported. And this is, again, just a protocol again, you can follow, you may already do this, it's just as a suggestion. So it starts at 5 milligrams. Actually, Nelson and Feldman, the gods of endocrinology, that recommend you doing this way. So it starts at 5 mg per kg twice a day, just to see if the animal will tolerate ketoconazole. If he tolerates, then increase to 10 milligrams twice a day. Do it for 2 weeks. And then if no side effects and there is a response, so not drinking a lot of water and starting not eating a lot, seeing some changes there, the hair will take a while, skin changes will take a while, so then it's good, continue with that dosage as maintenance, okay? You may change later on if the owner is not very happy, you want better response, that's okay. But depending on the case, you can use that as maintenance. So if there is, okay, here, if there is side effect with the 10 milligrams twice a day, reduce the dosage by 25%, give it for 2 weeks, okay? If no response, okay, consider other treatment. Obviously, if there is response, continue that as maintenance, okay? Now, you are doing 10 mg per kg twice a day, okay? So, no side effects and no response, then increase to 15 milligrams twice a day. Go for 14 days, okay? Then side effects, reduce the dosage, 25%. See if side effects go away. If no response, but also no side effect, consider other treatment. Because this is already high. This is, we are giving 30 mg per kg per day in these dogs. If no response, go. Ay, poor you. Okay, so then we go here, no side effects. We are at 30 mg per kg per day, no side effects. In response, continue as mentioned, as maintenance, no side effect, plus no response, discontinue. That's what I would recommend. Okay, so monitoring for any of the medications that you use, looking at the patient, it's the most important thing, okay? It's the most important thing. And I don't know what to do for ketoconazole here. I actually kind of did a way on myself. I know urine cortisol calibration is not a good way to monitor because you are going to see a lot of variations there. You can do the baseline cortisol, okay? So it can be just before the dosage or after. I'm copying this from the protocol we use for trilostane, okay? Or it can be before or 3 hours after, okay? That's the range that you want to reach, okay? Or ACTH stimulation test. I like the ACTH stimulation test for a lot of this, to monitor response to a lot of these treatments, okay? And that's where you should get. Retinoic acid, I never use it to treat Cushing's disease, but Nagarajan told me that you guys use isotretinoin here. So I looked in the literature and I found one paper where they use retinoic acid in dogs, but they didn't use isotretinoin. They have used isotretinoin in people, but I didn't see any in dogs, which again, isotretinoin is a 13-cis-retinoic acid, and the one they use is this 9-cis-retinoic acid, or it's iletretinoin, okay? And they actually had a group of dogs on this drug and a group of dogs on ketoconazole at 10 milligrams twice a day. And they use, I think, I'll show you in a minute. What's interesting about the retinoic acid for Cushing's is that it decreases the synthesis of ACTH, not only from the anterior portion of the hypothalamus, the pituitary, in the pars intermedia also. And so, but it doesn't do anything if the animal has an adrenal tumor. It's only for pituitary dependent. And according to the authors of that paper who have done studies in people, there is also a reduction in size of the tumor. So this is, I thought it was interesting in that way. So, but there is limitation there. See, this is a study, and they use it in 22 dogs with pituitary dependent Cushing's. They use that product, 2 milligrams per kilogram per day for 6 months, and they saw improvement in all the parameters that they use to assess these patients, and the ketoconazole portion also improved very much so also, but had no effect in the tumor. And that's what they said. This is much better than ketoconazole because we have an effect in the tumor. Ketoconazole doesn't do anything like that. 5 of the 22 dogs died. And so in 2, I think if I recall, 2 of these dogs had what they say a macroadenoma. They blame to that. I forgot what the other one had. The other ones were due to other things, but they don't think was related with the treatment. Okay, L-Deprenil. Have you heard of L-Deprenil to treat Cushing's disease? It's another disappointing drug because when it came out safe, yes, it's wonderful because they said that there was quite a few results, excellent results. Quite a few of us used that at the beginning, kind of disappointed. But there is still a place for L-Deprenil to treat the disease. So it's used primarily for cognitive. It's selegiline, so cognitive disorders, okay? So what it does is inhibit monoamine oxidase beta, okay? That enzyme breaks down dopamine. And then we increase the concentration of dopamine in the pars intermedia because ACTH secretion is controlled by dopamine only in the pars intermedia. Only 30%, 1/3 of dogs with pituitary dependent have abnormality affecting the pars intermedia. So again, it's not that good in that way. So in which situations are you use trial Deprenil? Mild cases of pituitary dependent Cushing's. We don't know if it's in the pars intermediate or not. The chances are will not be involved in the pars intermediate, so then the chances that this drug will do much are very small. But again, the owners that are concerned about giving medications that cause hypoadrenocorticism when you are treating, or again, the cortisol-associated hypoadrenocorticism can also occur. So just because the cortisol level goes very low and they again have vomiting, diarrhea, significant lethargy for that, not necessarily aldosterone related, which can occur with the other medication. But this doesn't, it's safe. Indeed, that elderly couple that I'm concerned of using these medications with more severe side effects, or owners that cannot look at these dogs closely when you are inducing with the induction phase, which is for midotane only, or controlling the disease, because it needs a lot of communication. It takes a while so to control this disease. Then I will think of L-Deprenil. And this is the protocol. It's there for you. Let's skip that. I always start with the 2. If I'm using it, 2 milligrams per kilogram, I skip the 1, because they say start with 1 milligram per kilogram, go for 30 to 60 days, because it's cumulative. It takes a while to have an effect. You know, these drugs for cognitive disorder, that's how it happens. So very safe, minimal side effects there. Trilostane. So you don't have trilostane here yet, right? I bet you're going, DECRA will bring it to you. But that's the drug that I would say, I never say 100%, but at least 90% of people in the United States are using. And I think midotane is even better than trilostane to control the disease, but because it's safer. And the reason that the inhibition of the enzyme involved, this 3-beta-hydroxysteroid dehydrogenase, it's reversible. Okay, so that's why it's safer, and then we're using it more often. Efficacy, it's pretty good. Okay, side effects rare, but you can have anorexia, lethargy, and then really hyperadrenocortisol. So you can say what the internal medicine is, the cortisol-associated hypoadrenocorticism, or truly aldosterone related, okay? And adrenal necrosis. When you treat with myostatin or PDD, you're causing adrenal necrosis. But here you don't want to cause adrenal necrosis, not the mechanism of the action, but it can occur in some cases. In the cases reported, they actually died, but it's rare, okay? People are usually not concerned about, it's not working, oops. Okay, so starting those, you see, this is what DECRA recommends in the package insert, 2.2 to 6.5 milligrams once daily. So start with the low end, okay? And then see with time you increase the dosage. Most people are doing it twice a day. DECRA tells you, and the veterinary is associated in, you don't need to do it twice a day, at least initially, okay? Because how it's metabolized, it's short, okay? So, I mean, it's fast, and then it doesn't last very long. The half-life, I should say. It doesn't last very long. So monitor, give it with food, okay, to improve absorption. So you're looking at the clinical signs, Nagarajan, did you give to them that questionnaire that I sent you, or? Oh, it's in there? Yes. Because you can use a questionnaire. This is, again, what's published, and to really assess your patient, your cushingoid patient, okay? So it guides you with important questions for you to answer and do a checklist, okay? Then you do a serochemistry profile, electrolytes, and cortisol levels. And you do that in 2 weeks, 30 days, 90 days. And you can modify that a little bit. Very important to have a good client education and close contact with your client, okay? Well, look at the question mark. Nobody knows the best way to monitor response to treatment for trilostane. Initially, ACTH. And DECRA is still, I say DECRA because they manufacture it, but it still recommends ACTH. If you look at their insert package, that's what they recommend. They think a paper came out looking at this ACTH results and how the patients are feeling. And there wasn't a good correlation. And then people start saying, hi, how do we are doing this? And then you could do baseline cortisol, okay, before trilostane. It's just before trilostane, about 3 hours after, or ACTH stem. I'm just going to talk about, if you guys, you can tell me to stop. He's telling me to stop already. Okay. But those are the two ways. And you have in your notes exactly how it's recommended. And there is a guidance of the range of cortisol for you to make a decision which way to go. And after this one, it's myostatin. Do you have myostatin? So then you don't have myostatin, you don't need to worry about it, okay? Which is very good. Again, myostatin is very, very good too. So, okay, well, thank you, and go home. Okay.